cells.
Target cells, yes. There are few there, okay. Oh, sorry. So, okay, one here, one here, one here. Okay, there are a few more. Okay, one here. Okay. So yes, target cells. Any more? So marked anisopoikilocytosis, nucleated red cells, Howell-Jolly body, target cells. Okay, don't waste time. You also see hypochromic, isn't it? Hypochromic and also microcytic. In addition to that, you also get cells which are like this. 1, 2, 3. Can you see that?
Yes.
Yes, that.
Yes.
What do we call those cells?
Reticulocytes.
Yeah, they are actually reticulocytes, but what in this sort of stain, what do we call them?
Polychromatic.
Yes. So when you ask to describe this cell, this is a polychromasia. Okay, they are polychromatic cells. Okay, so microcytic hypochromic blood picture with nucleated red cells, polychromasia, and some Howell-Jolly bodies. Okay, so this is what you see in the patient with beta thalassemia major. Okay, the Howell-Jolly body, okay, can become more obvious in patients who have their spleen removed. Okay, because the spleen is the one where the inclusions gets trapped, they get removed by the macrophages. So when the spleen is removed, you have no removal of this inclusion anymore. So they appear, a lot of them appear in the peripheral blood. Okay, so this is beta thalassemia major, and this is the outline of that patient's enlarged liver and spleen. Okay, so this is the liver on this side and the spleen on this side. Okay, liver here. So this is the outline marked to you. So because you cannot feel it in the picture, so it's marked for you there. Okay, let's move on to this is also not a patient of mine, a patient of my colleague from Semenanjung. All right, so 72-year-old retired Indian rubber taper who came in with insidious onset of increasing tiredness and lethargy for 3 months. He is a chronic alcoholic, consume a lot of types of alcohol, ranging from toddy to beer to hard liquor. I'm not sure whether you're familiar with toddy. When I was studying in UM, I had tried toddy, so I know what it is. Anybody not familiar with toddy?
No, only tiger.
Only tiger. All right, anybody knows toddy? Can you explain? I'm sure people from Semenanjung have heard this.
No, doctor, never heard about it.
Never heard.
That's from kelapa, from
yes,
coconut.
yes. You Faisal, is it? Okay. Yes, it's from coconut. Okay, so it's something like fermented kind of coconut, but I think you have to prepare it on the tree itself, if I'm not mistaken. Okay, so it's a drink from coconut. Okay, but because it's a fermentation process, so there is some alcohol there. Okay, not very much though. Okay, but there is some alcohol there. All right, so the hemoglobin is 4.5. Total white count is 3.8. Platelet count is 98. So you can see from here, okay, that all these counts, okay, are low. Okay. Now, do you know the term that is used to describe when all the cell counts are low?
And cytopenia.
Very good. Pancytopenia. So this patient has pancytopenia. The MCV is 112, which is higher than the normal range. The MCH is 32, still within the normal range. All right. So, so what further question you want to ask in the history? You know that this patient is anemic. Okay, you're given some information there. Now, I think I want to remind you here that this is quite a complicated case. Okay, because with the history of chronic alcohol consumption like that, later on you learn that a patient can have chronic liver disease. Okay, chronic liver disease can cause anemia as well. Alcohol abuse per se, even if it hasn't caused chronic liver disease, also can be associated with anemia. So it's not a straightforward case in this one. I'm just reminding you, but I still want to insist on asking you, what question would you like to ask further in the history?
Maybe the frequency of the alcohol consumption per day or
Okay, yes, yeah, it's every day. Okay, it's every day. Yes, you want to ask. Actually, you want more details on the consumption. Okay, and later on, you will be taught how to ask whether the patient is dependent on alcohol. Okay, so you want to ask the actual amount. Okay, but when you record in your documents, you try to translate them into units of alcohol. The patient can tell you that, doctor, I drink 3 cans of beer every day. You have to translate that into units. How many units is that 3 cans? Okay, so I'm not going to teach now. Okay, later on you discover that. So yes, you have to find out about that. Okay, and in terms of alcohol consumption, also you have to find out whether there is any evidence of this patient having, you know, being alcohol dependence. Okay, so there are a few questions later on you'll learn. Okay, how to determine whether the patient is alcohol dependent or not. Okay, we're not going to go through now, but yes. Okay, but we are more targeted now on the finding the cause for the anemia. Okay, so what question?
Probably medication history.
Very good. Yes, medication important. Okay. Any more?
Can we also ask if they ever vomit blood?
Okay, yes. Very good. Yeah, I mean, complications. Again, you haven't studied this, but complication of chronic liver disease due to alcoholism, they can have esophageal varices. And when you have esophageal varices, vomiting blood is quite a problem. Okay, so yes. Okay. That's what I say just now. You can ask the right history, but at the moment you don't know the right reason. Okay, the reason is chronic liver disease. You can have esophageal varices, which can give rise to vomiting of blood. Okay, any more? You forgot something. In this patient, maybe I just tell you straight. This patient is dietary history important. Okay, he drinks alcohol. Okay, he gets groggy every time. Okay, he doesn't eat well. Okay, so his diet is mainly liquid diet, alcohol. So he has poor meals. Okay, so dietary history is important. Okay,
Sir,
so yes,
dependent alcohol means he cannot live without alcohol, is it?
it's like drug dependence. In fact, alcohol dependency is like a drug dependency, meaning yeah, you cannot live without alcohol. Okay, so maybe I tell you like what do you call that? I think it's still used nowadays. We have a set of questionnaire, simple questionnaire to ask patient to find out their likelihood of being alcohol dependence. We call it CAGE. Okay, CAGE, CAGE. Okay, so that's a CAGE questionnaire which we ask. Okay, so have you heard of that?
No, doctor.
No, no.
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 Okay, so cash C is for cut down. Okay, so have you do you think that you drink too much that you feel like you want to cut down? Okay, so if the patient say yes, is 1 point suggesting that. And then A is angry. Okay, when people say that you drink too much, do you get angry? Okay, all right, so there's another point pointing towards dependence. Okay, G is for guilt. Do you feel guilty that you're drinking too much? Okay, okay, so if they have that, again, it's another point. E is eye opener. Okay, so if you don't drink in the morning, are you able to work? Okay, those who are really dependent, they even drink early morning. Okay, otherwise they cannot do anything without drinking. So there are some points assigned to each, and if they achieve certain score, that confirms a dependency. Okay, so I will not go into more details of that. So yeah, it's like drug dependence. All right, so history in this patient, as I said, is mainly the diet. So what signs that you want to look for in the physical examination?
Liver enlargement.
Very good. So yeah, I mean, you want to look for signs which can give you clue as to the cause of the anemia. Okay. As I said in the beginning, this is a bit complicated case. Okay, so you want to rule out a chronic liver disease and liver cirrhosis. Okay, so you want to find out whether the liver is enlarged or not enlarged. Okay, any other signs of chronic liver disease? Okay, jaundice, enlargement of the breast in men, loss of axillary hair in men, women as well, parotid swelling, fluid in the peritoneal cavity, ascites, so there will be distended abdomen. Okay, some signs on the chest, which we call due to dilated capillaries, we call them spider nevi. Okay, so these are signs of liver, chronic liver failure, liver cirrhosis. Okay, so you also want to look for if there are any other specific sign for specific cause of anemia. Okay, all right. So those are the things that you want to look for in the physical examination. Now, in this patient, there is no signs of chronic liver failure. He had no jaundice. He had no liver or spleen enlargement, no ascites. Okay. So that's what I can tell for the time being. Okay, I'll show you the one sign later on. So when you ask to comment on the full blood count result just now, okay, anemia, sorry, this is not just anemia, this is pancytopenia. with high MCV. So this is macrocytic. Okay, macrocytic. So you have learned from the lectures some of the likely causes of macrocytic anemia. All right. So you have to investigate based on that. All right. So this is the blood film of this patient. Okay. So you want to comment on this? This is a small lymphocyte. Huh? Comment on the red cell morphology.
Can we say anisocytosis?
Okay. Yeah, some variation in size. Correct. Anything else?
Stomatocytes.
Okay, there's one there. Okay, any more?
Presence of hypersegmented neutrophil.
Yes, you can see here. Okay, it's a hypersegmented neutrophil. Okay, now in this one here, this is from another patient, just to show you the hypersegmented neutrophil there. Okay, so but this is from this patient. Any more from this slide? From this one here?
Teardrop cell.
Okay, yeah, this one teardrop here. What about this one? Do you recognize this one?
Could it be a reticulocyte, doctor?
Possible, yeah. And this one? And maybe this one also?
Ovalocyte.
Oval macrocyte. Oval macrocyte, because you see the diameter is bigger than this small lymphocyte, but they appear oval. So these are oval macrocyte. Okay, so these features are quite typical of megaloblastic anemia. Okay, so this patient had some form of megaloblastic anemia. Okay, we investigated further. Okay, B12 level was normal, but folate level was low, and his liver functions were still within normal range. So he doesn't have chronic liver failure. So the cause of the problem in him is folate deficiency. Okay, folate deficiency. Okay, let me show you one more. Okay, my colleague gave me his picture here, but he only wants this part taken, no other parts. So shows you what does this picture show in the tongue? Two findings in the tongue.
Glossitis.
Very good, glossitis one. And another one?
Pallor.
Yes. So pallor and glossitis of the tongue. Now, if you are asked to examine a patient with anemia, the best place to look for pallor is actually under the tongue. Okay. The palms is can be misleading because the palms can be pale if you are in a cold environment. Okay, but under the tongue is not affected by temperature changes. So it's the most accurate place to look for pallor. It's under the tongue. Conjunctiva better than palm, okay, but extreme conditions still can be affected. Okay, so pallor, best place to look for is under the tongue. Okay, let's move on. This one is a patient of mine, okay, several years ago. Again, I saw him in the private hospital initially, but when I did some what do you call it, visiting work in SGH, Sarawak General Hospital, she followed me there for follow-up. So I saw her for some years. Okay. So yeah, she's a 16-year-old Chinese girl, was a student at that time, who presented with history of progressive tiredness and lethargy. So she always asks excuse not to take part in the physical education classes. She also noticed that some slight yellowing of her eyes, and this is her blood count. Okay. So hemoglobin low, total white cell normal, platelet normal, mean cell volume, MCV still within the normal range, isn't it? MCH still within the normal range. Reticulocyte?
High.
High.
Yes, reticulocyte high. And the peripheral blood film shows some occasional nucleated red cell. Okay, when she was when the blood test was done at that time for this one. Okay, so again, what further questions in the history? You have been given some information earlier on that she had tiredness and noticed a little bit of a yellowing in the eyes.
Diet,
Diet?
diet history.
Okay. Okay. Yeah, and I mean, in any anemia, of course, you want to inquire about dietary history, but in patients who is anemic and also have yellowing eyes, which is most probably jaundice. In addition to that, what else would you like to ask further?
Disease history and family history of disease.
Okay. Okay. Asking for, specifically asking for what?
Thalassemia.
All right. Yeah. So you want to rule out whether there's any family history of thalassemia, okay, any past medical history. Has the doctor told her that she got something? Okay, yes. Anything else?
Ask the patient whether she consume any alcohol.
Okay. Okay. Yeah. Okay. So I think acceptable. Okay, but of course it's because now that you as I said you are still in the early stage. You haven't learned a lot of other system, so it's a bit difficult for you. But never mind. I'll mention a bit later. Okay, after we discuss the other questions here. And what physical sign do you look for in this patient? All right, the usual signs of anemia. Okay, pale, okay, jaundice. This patient has slight jaundice. This patient has pale conjunctiva. Okay, so what else will you look for?
Hepatosplenomegaly.
Okay, this patient has a spleen which is just tipped, meaning that there is enlargement. You shouldn't tip it at all. Okay, so this patient has spleen which is just tipped. Okay, yes, so those are the things that you want to look for, but there will be a bit more actually you want to look for, but as I said, because of your limited knowledge at the moment, so you are probably not able to come up with the rest. Okay, but never mind, I will tell you a little bit more after we discuss all the other questions here for this one. Okay, let's look at the peripheral blood film. Okay, the blood count as we saw just now, high reticulocytes with anemia. So this is the peripheral blood film, okay, which I want you to This is not this, exactly from this same patient. It's from another case. Okay, but similar lah. It didn't show you the nucleated red cells which was reported in this patient. So what do you see from this peripheral blood film, which is similar to this patient's one?
Some red blood cells are macrocytic and polychromatic.
So you can call this polychromatic. All right. Yes, so there's polychromasia. Good. Any more?
Can we say there is ferrocyte present also, doctor?
Very good. How many of you noticed that? Okay, there are few here. Okay, there's one. These are microspherocytes. Okay, in fact, there are few of them. Huh? Okay. I'm just circling a few here. So there's some spherocytes. All right, so there's some anisocytosis. Okay, there is a polychromasia and some spherocytes present. Okay, so that's the peripheral blood film. Now back to the classification of anemia again here. So if you ask to classify this anemia morphologically, this will still be nomocytic anemia, isn't it?
Yes.
Right. If you are asked to classify this anemia according to the kinetic classification, this will be hyperproliferative anemia. Correct?
Yes, doctor.
Right.
Yes.
Okay. So this patient has, I mean, that if you ask to classify in those two ways, okay? And you already asked to describe the morphology of the red cells just now. Okay, you can see some microspherocyte, anisocytosis, some microspherocyte, and polychromatic cells. So what sort of condition give rise to this picture? What sort of condition do you suspect when you see this picture? What conditions do you get spherocytes?
Hemolytic anemia.
Hemolytic anemia, very good. What kind of hemolytic anemia do you get spherocytes? Not all, huh?
Autoimmune?
Yes. Autoimmune, you can get spherocytes. Okay. Any other condition you can get spherocytes? Okay. Spherocytes generally autoimmune hemolytic anemia and congenital or hereditary spherocytosis. Okay. But in hereditary spherocytosis, you get much more spherocytes than this. Okay. So this girl actually has autoimmune hemolytic anemia. Okay, and it was confirmed. We did a direct Coombs test on her. Okay, which was positive. Okay. I didn't explain about direct Coombs test other than saying that it is a test to detect the presence of antibody coating red blood cells. Okay, so I didn't explain more than that, but if you're interested, you can read further. I think there is mention about it in Hofbrand, okay, the essential hematology. Okay. All right, let's move on to the next case. Okay, yeah, before I forget, maybe I emphasize this point. Now, autoimmune hemolytic anemia, okay, so it can be primary, meaning no non-cause, or it can be secondary to other causes. One of the important cause of secondary autoimmune hemolytic anemia in this country is systemic lupus erythematosus. Okay. Now in this, so in patient with who you suspect to have autoimmune hemolytic anemia, you have to ask about history of symptoms of lupus. Okay, especially females, because much more common in females. But in this girl, there's no history when she came. Okay, so like facial rash, okay, joint pains, okay, hair loss, okay, this sort of thing should be asked. These are some of the symptoms of lupus. There'll be more that you will learn later. Okay, so in the older patients, you want to rule out autoimmune hemolytic anemia secondary to some blood malignancies, lymphoma, chronic lymphocytic leukemia. Okay, so but as I said just now, because your knowledge is at this moment a bit limited, so you still don't think of that in the history, but these are the things which are important to us in the history for this sort of patients.
Sorry, doctor.
Okay. Yes.
For just now the case, if it's autoimmune hemolytic anemia, why there is no agglutination?
Okay. Anybody wants to answer that question? Okay. Sorry. This I didn't specify. Okay. This patient had warm autoimmune hemolytic anemia. Okay. The antibody is IgG.
All right, doctor. Thank you.
Yeah. So do you know why IgG don't give agglutination? The IgG molecule is not
Just the
big enough.
structure.
No, the molecule is not big enough to span the width between the two red cells. Okay, so when IgG is coating the red cells, it doesn't give rise to agglutination. When IgM is coating the red cells, that's when you get agglutination. Okay, so IgM, as I saw, I've given you in the slides yesterday, IgM is a cause of cold autoimmune hemolytic anemia. Okay, so you generally don't get agglutination in warm autoimmune hemolytic anemia, but you get agglutination in cold. All right, okay. This one is a patient who was presented to me by when I was teaching a year 5 medical student several years back. So during the bedside teaching, they presented this case. Okay, an 18-year-old, this is from Sarawak General Hospital. Okay, 18-year-old male Iban mechanic presented with a history of set of increased tiredness and lethargy for 3 days. He also noted dull ache in both and noted his urine was dark colored. Hemoglobin 6.2, which is low. Total white cell count is 7.8, normal range, within the normal range. Platelet count within the normal range. MCV within the normal range. MCH within the normal range. Reticulocyte increase, and occasional nucleated red cells in the peripheral blood. So again, back to the classification just now. Okay, if you use the morphological classification, this is normocytic anemia. All right, normocytic anemia. If you use the kinetic classification, this is hyperproliferative anemia. Correct? Do you all agree?
Yes.
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 All right, so what do you need to ask further in the history?
Can we ask if he was exposed to any like poisonous substances?
Okay, very good. Very good.
What about drug or medication history?
Yes, yes, very good. So you want to find out whether he has been taking drugs, okay? No, he said no, he hasn't taken any drugs, but he said a few days before this, he had flu-like illness with slight fever, running nose, and cough. He has not taken any drugs. But that resolved, the flu-like illness resolved. Okay, yes. So those are the things that you want to ask in the history. Anything else other than that?
Doctor, can we ask the patient if he have have any injury to his back, like if he had accident, it can cause the injury of the bone marrow?
Okay, yeah. No, I mean, it's very difficult to injure the bone marrow. I think here maybe you can talk about injuring the kidneys, okay? Because he had loin pain and dark urine. All right. Yeah, no history of injury. Okay, he's a mechanic, but he didn't injure himself.
Maybe infection, doctor.
Okay. So what do you have to ask if you're thinking of infection? No more fever, he said.
Yes.
Any other question?
Like food allergy?
Okay. I think in this sort of case, I think I want to emphasize the point again that you want to find out whether he had similar episodes before. Okay? Whether he had similar episodes before. Now, actually for this patient, he said he never had this episode before. But actually, when we think back to this patient, I think it's very difficult to believe that this is the first episode, okay? So physical signs, what do you want to look for in the examination?
Signs of renal failure.
Okay. Example?
Edema.
Okay. No edema in this patient.
Pardon?
Yes, very good. Okay, I mean the general signs of anemia, pale. Okay. If I tell you that this patient had jaundice, mild jaundice,
Spleen and liver enlargement.
okay, no spleen and liver enlargement,
How about blood in urine?
okay, he had dark urine, but yeah, I mean the dipstick, the dipstick test show that blood is positive. Do you know what is urine dipstick?
No, doctor.
No. Dipstick is some kind of strip, which there are a lot of things that put on that strip, that test strips. You just dip it into the urine, and you get the color change, and you interpret the pH. Okay, whether it indicates whether there's presence of proteins, presence of glucose, okay, nitrites, blood, and so on. So that's the urine dipstick. Okay, so it's a test strip that you dip into the urine. So it's something like a test kit, but a very simple one. So that indicates positive for blood. Okay, but I must tell you that urine dipstick, which says it's positive for blood, is not specific for blood. Other things can cause it to become positive for blood. All right, so I mean the physical signs that you look for here is, again, I want to emphasize the point is you want to look for general signs of anemia, the complications of the anemia, as well as trying to find the cause of the anemia. Okay, so in this patient there is palo, there is jaundice, mild jaundice, there is no spleen, no liver palpable, okay, and he's got no other signs of complications, no signs of cardiac failure, no edema, so on. So it's just palo and mild jaundice. Heart rate increase. Okay, that's probably the tachycardia due to the response to the anemia. Okay, lungs are clear. Okay, respiratory rate still within the normal range. So if you have anemia and jaundice with this sort of thing in the history, dark urine, what is the thing that you suspect? What kind of anemia is this you suspect?
Hemolytic.
Hemolytic anemia. And where is the hemolysis occurring? You think, is it in the spleen or is it in the blood vessel?
Intravascular.
Intravascular, isn't it? Because of the dark urine. Okay, because of the dark urine. Okay, so we have commented on the blood count results. I want to show you the peripheral blood from here. Okay, do you notice anything here?
A lot of bite cells.
Yeah, there are a lot of bite cells. Okay, they're quite obvious. I'm just marking two for you there. Okay, so what type of hemolysis is it when you get bite cells?
Oxidative stress.
Very good. So it is some form of oxidant-induced hemolysis. Oxidant-induced hemolysis. Now, this can be due to some strong oxidant drugs, or it could be due to somebody with G6PD deficiency who don't have the capacity to neutralize the oxidant. Okay, now this patient doesn't have history of taking any drug. Okay, so we did a test on this patient and found that he had G6PD deficiency. Okay, so this patient had G6PD deficiency. Again, the funny thing is, this is the first episode that he is having it. He said he denied any history of previous episode. Okay, cannot explain that. So it does happen. The other thing which is funny is we asked him whether he has been told that he has G6PD deficiency. He said never. In this country, G6PD screening is done at birth. Done at birth. And if it is for patients who are G6PD deficient, if they are detected at birth, normally they are told. Okay, they are told. The parents are told they have that in their baby card and therefore they should know it. But this patient said no, never. But he cannot produce his baby card. So we don't know what the screening result was. But we assume that it was, what they call that, it was not deficient because he was never told during the screening. So what does it mean? It means that screening can be, what they call that, can have a false negative. Okay, so this patient had G6PD deficiency found at 18 years old due to an acute episode of hemolysis. Okay, but it is confirmed by doing the G6PD test plus the typical blood film. Okay, so just to illustrate to you. Okay, but this picture, if you don't know the case, okay, any oxidant-induced hemolysis will give you this blood picture. Okay, somebody who drank chlorine because she wanted to commit suicide, drank a lot of chlorine. We get this picture in the blood film. Okay, due to oxidant-induced hemolysis due to the chlorine. Okay, next case. 20. This is not a case of mine. Okay, it's a case of my colleague. Okay, so 28-year-old Malay club was admitted for extreme lethargy following a flu-like illness. Again, similar flu-like illness. The mechanic just now also had some flu-like illness before he developed the tiredness. Although there was only when we asked him, he said. But this one is club, it's volunteer the information. This is his fourth admission in the last 5 years. So this is not the first time. And he was also told that he had been investigated for yellowing of the eyes when he was 8 years old. So you got some information from there, the initial history, that this problem probably has been ongoing for some time. Okay, but now he's developing extreme lethargy. Hemoglobin 6.5, you know that's low. Total white 7.2 within the normal range. Platelet 1 at 5 still within the normal range. MCV 86 still within the normal range. MCH 33 still within the normal range, but high normal. Okay, high normal. Reticulocytes 11%, quite high. Okay, so if you use the morphologic classification, this is normocytic anemia. If you use the kinetic classification, this is hyperproliferative anemia. Agree?
Yes.
Yes.
All right.
Yes.
Okay, so this is, you would have guessed now, this is also another kind of hemolytic anemia. Okay, the reticulocytes increase, okay, low hemoglobin. MCV indicates is normocytic. So hemolytic anemia can come under normocytic morphology, but some fall under macrocytic. Okay. So what further question you want to ask in the history? Again, here you want to actually find out, in addition to the usual symptoms of anemia, you want to try to find out the cause. Okay, so anybody wants to volunteer? What further question to ask?
Has he been diagnosed with any blood disorders
Very good.
previously?
Very good. You see, he has been investigated at 8 years old. So has there been any definite diagnosis? Yes, you should ask that. Okay. Now, quite often there is, okay, I'm sure doctors will be able to make definite, but sometimes there are problems. You know, sometimes cases can be difficult that the doctor just tell you that something wrong, but we cannot really tell you what is wrong. That's the problem. Okay, I had a case 2 years ago. Okay, this is an elderly gentleman, 70 plus, who came to me. He feels unwell. Okay, and the blood count show a little bit raised lymphocyte count, and we did some tests. Show some abnormalities. So I did further tests. Immunophenotyping show that there is a clone of abnormal cell, but not enough to call it leukemia. Okay, so but if you get enough numbers, okay, let's say you get more than 20%, for example, you can call it leukemia. This is mature lymphocyte, okay, but not enough to call it leukemia. But they are abnormal and they are clonal. They express only one clone. Okay. So what do I call it? I don't know. Okay? I consulted my colleague. I even emailed another specialist who I know in Singapore. Nobody knows that. So we end up telling the patient, okay, there is something wrong with you, but we can't tell you. So the patient is so frustrated. He told me after that, few months after that, he went to Bangkok. Still cannot get the answer. He went to Singapore. Still cannot get the answer. He came back to me. So difficult, doctor. I just don't know what's wrong. I went to several places. Nobody can tell me what's wrong with me. But the good thing is he's still alive. Even though there's something wrong with him and something abnormal, he's still alive. So sometimes you have to do that. So in this patient, back to this patient, you have to ask whether there's any definite diagnosis previously. Very good. So you have to ask that in the history. Okay, any more things you ask in the history?
Family history.
Maybe
Very good. Family history, yes. Family history of similar condition. Okay. Siblings, parents, okay. Because it could be familiar, something familiar. Okay. Anything else?
infections, doctor.
Infections. Okay. What's the relevance of infections here? Causing the hemolysis, is it? Anything else?
Doctor, how about medications?
Okay, yes. All right. Whether he had been prescribed medication. Okay, so I think you're on the right track, but as I said just now, because of your limited experience, so the other things cannot come out yet, but never mind. You will slowly get to them when you are more advanced. So I think it's okay for the time being. I think in terms of asking you for exam, we probably will be more targeted rather than asking so broad. Okay, so don't worry too much. Physical science, again, you want to look for, as we mentioned previously, we always want to look for signs, general signs of anemia, and look for signs which gives clue as to the specific cause, and of course complications. Now this patient physical examination show mild jaundice, pale mild jaundice with some enlargement of the spleen. Okay, so there is pars splenomegaly. No other signs except for those. Okay, so we have commented on the full blood count results. Let's look at the peripheral blood film. Okay, easy this one?
Spherocytosis.
Yes. This one you see microspherocytes, and they're more than the girl with the autoimmune hemolytic anemia, isn't it?
Yes.
They're much more. Maybe I would say 70%. Okay, in this field alone, I'm not sure. Okay, but they definitely much more than the earlier case. All right, so this patient actually had a hereditary spherocytosis. I told you yesterday, this condition is common among Northern European, but we also do see a few cases in our country. As I told you, I had some experience with cases from Bintulu. Okay, so why patients with hereditary spherocytosis have enlarged spleen?
The spherocytes get stuck in the spleen, so they get destroyed.
All right, so yeah, I mean it's because of the spherocytes being not as deformable as the normal red cells, so they get trapped in the splenic circulation, and that gets destroyed there by the splenic macrophages. So it is causing increased workload of the spleen to destroy these spherocytic cells. So that's why you get splenomegaly. Maybe I ask you this question here. Okay, do you get does extravascular hemolytic anemia lead to iron deficiency? I think this is an important fact for you to know.
No.
No. Okay. Then the next question, does intravascular hemolytic anemia lead to iron deficiency?
I don't think so.
You don't think so? Maybe I rephrase the question. Okay. Do you get iron loss from the body in extravascular hemolytic anemia?
No.
No, okay. Do you get iron loss from the body in intravascular hemolytic anemia?
Yes.
Yes. How?
Yes. Heptoglobin binding with hemoglobin.
But heptoglobin binding with hemoglobin is taken by the liver cells, isn't it? So it's still in the body.
It's the hemosiderin.
What happened to hemosiderin?
It gets excreted in the urine.
Okay, but those are the hemosiderins which line the tubular cells of the kidneys that get excreted in the urine. So actually the loss, I mean there's loss, okay, but probably not very much. But yeah, I'm asking for loss, yes. So you do get loss in that sense. Okay, maybe I ask you another question before I come to the point. Okay, where is most of the hemoglobin in the body found? Sorry, I already give you the answer. Okay, my mistake. Okay, iron in the body is mostly found in hemoglobin. 70% of iron in the body is in hemoglobin. Okay, this is an important point for you to understand. I'm not sure it should have been mentioned because I didn't give you lectures on. Okay. So in intravascular hemolysis, hemoglobin dimerize. Okay, some of them are bound to haptoglobin, but the haptoglobin levels is limited. So if there is a lot of hemolysis, the hemoglobin cannot have enough haptoglobin to bind to. So you have a lot of free hemoglobin which dimerize, and that hemoglobin dimers are small enough to pass through the kidney and get past in the urine. So you lose hemoglobin, okay, and because 70% of iron is in hemoglobin, so you lose a lot of iron in severe intravascular hemolysis. So actually in severe intravascular hemolysis, you can have iron deficiency because of the loss of hemoglobin in the urine. You do not get iron deficiency with extravascular hemolysis because iron, which is released from the red cells into the macrophages, are being recycled back. They are recycled back into the pool. Okay, so they bind back to transferrin and recycle into the pool. So that's the difference between extra and intravascular hemolysis. Okay, get that point?
Yes.
Okay, this case, I don't want to spend too much time because it's a bit advanced for you, but what I want to show you is mainly the red cell morphology afterwards. Okay, so this is a 25-year-old lady who is brought to the emergency department in the state of altered sensorium, meaning that sometimes conscious, sometimes recognize people, sometimes don't recognize people. Okay, but also with fever and bruises on the upper limbs. So there is altered sensorium, fever, bruises on the upper limbs. Hemoglobin 7.5 reduced. Total white 4.2, still okay. The differential count is normal. Platelet count very low. Reticulocyte count high. Direct Coombs test negative, so it's not autoimmune. Okay. Serum haptoglobin low. Okay, so you know this is some kind of hemolysis. Okay, low haptoglobin, increased reticulocyte, low hemoglobin, so hemolytic anemia. LDH very high, again also evidence of hemolysis. Okay, lactate dehydrogenase. Blood urea, serum creatinine, these are what we call renal function tests. Okay, so they're still within normal range. Bilirubin, a little bit high. Okay, and out of that, indirect bilirubin is the predominant one, which is 28. The direct one is 10 if you subtract it from that. Okay, so the predominant one is indirect. Indirect meaning unconjugated. Okay, so this is unconjugated bilirubin, which is then the conjugated one. So liver function test, AST, ALT is slightly raised for AST, but AST is not really specific for liver. Okay, red cells also contains AST, so that's why it's a bit raised here because of the red cell breakdown. Okay, you can see that the coagulation screening test here, the PT, APTT, and TT are normal. The fibrinogen is also normal. Okay, the CT scan of the brain was done because this patient had altered sensorium to rule out structural problem or structural causes in the brain. Okay, stroke and so on, tumors, was normal. Okay, so we have commented on the results. Okay, so what I want to show you is this blood film here. So what have you recognized from this blood film? What are the abnormalities?
Sickle cell.
Sickle cell.
Horn cell.
Huh? Foreign cell? On cell.
Horn cell, yeah.
On cell. On cell. Any more?
Some bite cell.
Again, what cells?
Some bite
Hypersegmented
cells.
neutrophil.
Bite cells. Hypersegmented neutrophil. No, the neutrophil is not hypersegmented here. I think there are only 1, 2, 3, 4 segments. Okay, you may mistake this one as a bite cell. Okay. Yeah, I mean you can mistake this one, but some other cells are not mistakable. Okay. This one, for example, this is the one you probably mistake for sickle cell. Okay. There's another one here. Okay, another one here. Another one here. Okay. So actually these are fragmented red cells. Okay. The other term which is commonly used is schistocytes. Have you heard of that term?
Yes.
Yes.
Right. So these are schistocytes. Of course, it takes experience to get to become familiar with recognizing these schistocytes. Now, this patient, okay, this case is an emergency because if you don't deal with it immediately, soon, this is life-threatening. Okay, so the diagnosis in this patient is both clinical and looking at the blood film. So it is very important to recognize the presence of schistocytes. Okay, this patient is a case of what we call, you probably haven't heard of this case. We don't expect you to know much at this stage. Okay, but as I said just now, I just want to highlight the blood film morphology. Okay, this is from a case of thrombotic thrombocytic thrombocytopenia. Thrombotic thrombocytopenic purpura, TTP. So thrombotic thrombocytopenic purpura, TTP. TTP. So it's a medical emergency because if you don't do anything soon, it's life-threatening. Okay, the prognosis is poor for patients. Okay, so I just want to recognize the presence of these schistocytes. There are several other conditions where schistocytes can be present. Okay, one of them is, remember the other day I talked about mechanical damage to red cells in the circulation. Do you remember I was talking about heart valves?
Yes.
Okay, so in prosthetic heart valves, you can also have this appearing. Okay, in much hemoglobinuria, you can also have this appearing. Okay, in a condition called disseminated intravascular coagulation, which we will come to cover during a talk on bleeding disorders. Also, you have these cells appearing. Okay, so there are several other conditions where you get schistocytes. But this one with the clinical picture, this patient had thrombotic thrombocytopenic purpura. Okay, and the treatment is of course plasma exchange. So you have to replace the patient's plasma with new plasma. Okay, generally it's done using a machine, plasmapheresis machine. Okay, so that's that case. Okay, this is a patient of mine. Okay, I saw this patient in a private hospital, okay, a few years back. But now, because I stopped practicing in the hospital, so he continued with my colleague in another private hospital, followed up there. So this is a 58-year-old man who presented with generalized weakness, fatigue, and shortness of breath on exertion for a few months duration. So examination showed that he was pale, the spleen was enlarged, okay, palpable 3 cm below the costal margin. There were no other findings in the other systems. Hemoglobin 7.8 low, white cell count 7.2 within the normal range. MCV high 108. Platelet count normal range, within the normal range. Reticulocyte count high. Heptoglobin low. Test positive. We do two types of direct Coombs test. One with the polyspecific reagent and one with the monospecific reagent. Okay. This is to determine what kind of antibody. Okay. Polyspecific reagent contains both IgG and anti-complement antibodies. Okay. Monospecific one is separate. So we have two types. One is IgG and only, and the other one is anti-complement only, anti-CD3D. Okay, so the monospecific direct Coombs test is positive for anti-CD3D, but negative for anti-IgG. So it means that the polyspecific here is positive because of the anti-CD3D. Okay, so what does it mean? Now you don't have the reagent for anti-IgM. So this is an indirect test for IgM, because IgM, when it binds on to the red cell, it fixes complement. Okay, and the product of that is you have C3D. So we can detect indirectly that IgM has been there because C3D is there. So you can detect that by using anti-C3D antibody in the Coombs test. Okay, so this is evidence that this is due to IgM. All right, so we have commented on the results. Okay. Okay, now this is what some of you mentioned earlier. This is autoagglutination. Okay, so this is autoagglutination. So this patient had autoimmune hemolytic anemia of the cold type due to IgM. And autoagglutination occurs at room temperature. Okay, this slide is prepared in room temperature. So if you want to prove this, what you can do is you can warm the slide, warm the blood sample, and then prepare the slide when the blood sample is still warm. You get much less than this. Okay, can you see the autoagglutinates?
Yes, doctor.
Right, so these are all autoagglutination. Okay, very big clumps of cells agglutinate together. Okay, so this is a case of cold antibody hemolytic anemia, called AIHA. Okay? Now, in most cases, this is associated with an underlying lymphoproliferative disorder. Okay, so this patient, actually we investigated further. He had lymphoma. Okay, so he had lymphoma. He's undergoing treatment for lymphoma with my colleague in the private hospital. All right, so just to highlight to you the morphology here is red cells agglutination. Okay, so when you're doing blood grouping afterwards, later on you have this blood grouping things. You actually can see similar agglutinates when you do blood grouping. Okay, the antigen antibody reaction Then you add a little bit of saline to that, take some drops of blood and examine under the microscope. So the blood grouping reaction is like this, because in the grouping reaction, you depend on red cell agglutination to determine the positive reaction. So it's something similar to this. Okay, but this is autoimmune hemolytic anemia of the cold type. Okay, I mentioned something like this yesterday for this case. Okay, yeah, 32-year-old Bidayo man from Kampong Bunan Gegak. I'm not sure any one of you knows where Bunan Gegak is. We did some research 1995. Okay, on actually we're doing research on nasopharyngeal carcinoma, but we did some blood tests for this patient and we found abnormalities. Okay, he got no symptoms at all. He was asymptomatic, no medical history of significance, never been admitted to hospital. Okay, the blood count also showed normal hemoglobin, normal total white cell, and normal platelet count. Okay, the MCV was a little bit microcytic. Okay, slightly microcytic. Okay, so this is the blood film. So you recognize the findings here?
Ovalocyte.
Ovalocyte.
Okay, yes. A lot of ovalocytes. And also things like this.
Stomatocyte.
Yes, stomatocyte. And this one is trying to talk, opening the mouth bigger. This one. Yeah, so ovalocyte, stomatocyte. So what is this condition?
Southeast Asia's ovalocytosis.
Very good. So this is Southeast Asia ovalocytosis. Yeah, I mentioned the other day. Okay, so this patient is asymptomatic. Okay, so it's a mild condition. It is supposed, this condition is supposed to be protective against malaria. Okay. Okay, last case. 69-year-old man, non-case of type 2 diabetes for a long time. Been undergoing hemodialysis for the past 3 years. You know why people undergo hemodialysis?
Kidney failure.
Yeah, you're not told here. You're not told here, but you know, you should be able to interpret when you are given this sort of information. Okay, so hemodialysis means that this patient had kidney failure. Okay. So he had that for the past 3 years, and he presented with tiredness, lethargy, feeling nauseated. Hemoglobin 8 low, cell still within the normal range. Platelet still within the normal range, slightly lower normal, okay, but still within the normal range. Blood urea high, so these are the what we call renal function test, blood urea and serum creatinine. Both of these are very high. All right, so evidence of renal failure still in the investigation, and also anemia. Okay, so let's look at the, you are supposed to look at the blood film. Do you notice the abnormal morphology here?
Yeah.
Combination of red blood cells.
Okay, so what are these?
Echinocyte.
Okay, yes. All right, so it's quite obvious here. There's so many of them. Yeah? Okay, so I think you encountered the term Burr cells, okay, which is also still commonly used for this type of condition. All right. So this is quite typical of chronic renal failure, usually signifying uremia. Okay, uremia. So in patients with uremic conditions, they tends to get this sort of morphology in the red cells. Okay, so let's look at the question B here. So in this patient, what do you think is the most likely cause of the anemia?
Kidney failure causes the decrease of production of erythropoietin.
Very good. So it's reduced erythropoietin production. Okay, so it's reduced erythropoietin production. But of course, when you actually work later on, even though that's the main cause that you suspect, okay, there can be other factors which contribute to the anemia. Some of these patients can have folate deficiency. Some of them can have iron deficiency, in addition to the erythropoietin. So when we treat patients with erythropoietin, we have to do iron level, folate levels, make sure they are not deficient. If they are deficient, we have to correct. We have to treat them with iron and folate. Otherwise, if we just treat with erythropoietin without knowing the levels of iron and folate, you may not get response because the patient could be iron deficient. So it is important to know the levels before you treat with erythropoietin and correct the deficiency. Only then will they respond to the erythropoietin treatment. Okay, so just remember that anemia can be multifactorial. Okay, but of course the main cause will be lack of erythropoietin due to the renal failure. Okay, so that's all the cases that I gave you, isn't it, for your red cell morphology? Only 10, isn't it?
Yes, doctor.
Yes, doctor.
Okay. Okay, this one, this is some one or two extra. Okay, this is just want to show you. What do you notice here?
Rolo.
Very good, very good. Okay, so yeah, this is rouleau. It comes from a French word, so it's pronounced rouleau. Okay, but the spelling is Rouleaux. So I was in the UK doing my clinical training last time. There's one English doctor who doesn't want to follow the French pronunciation. He pronounce it Rouleaux. Okay, so because he's quite anti-French. So I think the correct pronunciation is rouleau. Okay, but if you're anti-French, you can say rouleaux. So they are like a stack of coins. Okay, so this is a patient who had multiple myeloma. Okay, presented with malaise, lethargy due to anemia, as well as bone pain due to the bone marrow effect of the myeloma cells. Okay, so you have rouleau formation. There are a number of causes of rouleau formation. Of course, if you have very prominent rouleau formation, then you in the elderly person, you suspect multiple myeloma. Okay, of course, there are other causes as well. I think we skip this one. This is a bit difficult. Okay. Okay. 43-year-old man who has been working in the battery factory for 7 years. Okay. So has anemia, normal MCV, normal MCH, normal MCHC. Reticulocyte count is increased. This is the absolute count. Okay. Not the percentage. This is the absolute count. I just want to show you this. Can you all see this? This cell here.
Yes.
All right. So these are red cells with what we call basophilic stippling. Okay. Now, any clue from the history as to the cause of this patient's anemia and the red cell morphology?
Lead poisoning.
Very good. Yep, so he had lead poisoning. Yeah, this one we talked about, okay? 72-year-old man with a history of mitral valve replacement 14 years back and complaint of tightness. So you can see the cells that we talked about earlier. Few of them there. Okay, these are schistocytes. Okay, now this is a mechanical damage to the prosthetic. Okay? All right, I think 14 years ago, probably still metal valve, so you get more damage. Nowadays, they have tissue valve, so much less damage, but still can occur. Even with tissue valve, also still can occur. Okay, so schistocytes, several conditions you get schistocytes. Maybe, yeah, maybe that's all. Okay, so again, just to emphasize that, I just want to highlight the morphological changes of the red cells. Okay, a lot of cases of anemia that we cover. Okay, today, but there are also some other cases just to highlight the morphology of the red cells. Okay, any question? Any question?
So far, okay, doctor.
Okay, good. All right, so if no question, then we stop here. Okay.
All right. Thank you, doctor.
Okay, thank you all.